One of the primary reasons that all of us are in this room and have been working so hard on HIE to bring it to fruition is because we know the value of having accurate, timely data. And this is really getting to understanding the why of what it is that we've been working on. And you heard that earlier today, and I'm going to use that a lot because I really liked the way that that phrasing was. But it's timely and accurate data, not just at the point of care, but also for payment and population management. Our next panel is going to talk about the progress being made in using what's being termed big data. And that's become like the vogue phrase, big data. How big is big data? It's really, really big. But how big? How big is it? And what does that mean when you have big data? So I'm going to turn this over to someone that is very well known to many of you. She was my predecessor. She was the interim deputy secretary while, she also kept her other full-time job. I don't know how she did that. But Dr. Lynette Scott, who is now the Chief Medical Information Officer, new position, newly created, for the California Department of Healthcare Services. And they're going to talk about big data and using data to create change. Thanks.
Thank you. It's a pleasure to be here again this afternoon, and I'm very pleased to be here with Tom Williams and Ann Boynton, who have also been around this field for a very long time and much longer than I have, so I'm always thrilled to be learning from them. So I want to set the stage just a little bit and then turn it over to them to talk about real-life examples of how the big data of healthcare is being used to transform care. So let me make sure I make this all work right. You have to turn it the right way, maybe? Okay, got it. I'll hand it to you the right direction. Yeah. So the first part here, just to touch on, there really are a huge number of transformations occurring right now in healthcare. And one of the things just to highlight, there's been a lot of talk recently around the Health Benefits Exchange, the October 1 rollout. But just to pause for a moment and remind everyone, the Affordable Care Act passed a couple of years ago. We have been implementing it for a couple of years. It is not new this last month. And as part of that, there's been a lot of focus on changing the way we pay for care, the way we deliver care, the way we conceive of care, and having that go well beyond the doctor's office to include the different kinds of services, some of which were mentioned earlier by Dr. Hogarth with respect to long-term care services, emergency response, and also the community services that are critical to serving patients, members, individuals, us, to make sure that we can be healthy. And so one of the examples that we have in the Department of Healthcare Services that we're preparing for is our CalMedi Connect project. It's a duals demonstration funded through the Centers for Medicaid and Medicare Services. And the goal of this is to create coordination between Medicare, Medicaid, through our health plans, so that services that include clinical health, mental health, community services, in-home services are all being coordinated for that individual. And it's a very different way of working. And it has meant a lot of thought and consideration and planning and technology efforts and data efforts to make sure that we're ready for that when we start moving into that different environment. It's a big shift and a lot of growing and learning and getting ready. And so right now we're planning for an April 1st coverage date for that. And one of the things that's really critical is that it really is this care coordination. We're shifting the way we're going to be paying for care and looking at the quality of that. And so it's critically important that, and the health plans are working on this right now, getting ready, how they're going to coordinate with all these services and make that information move. So health information exchange and electronic health records play a critical role in that process. There are many challenges that come with the Affordable Care Act, things like major system redesign. We've been working on that under high-tech for a few more years than the Affordable Care Act, but these are major changes, huge volumes of data, looking at how to reduce cost. And so one of the things that you'll hear a little bit more of from Tom and Ann, the challenge here, one of the things we've talked about throughout high tech and the HIE environment is that whole evil word sustainability. And one of the things that's been changing, though, is we're really changing the way we think about information, how information moves. And so as we look at the implementations under high tech, affordable care, and the general transformation of the health environment, we're looking at how we reduce cost, improve quality, and improve the population health. So we're continually balancing that. So part of this is understanding where the return on investment is in terms of shifting the way we do our work and how the electronic exchange of information helps support that. So very much at the provider level, at the plan level, at the system level. Just to do the quick survey, who's heard of the National Quality Strategy? Okay, we're doing a little better than last time I asked that question. But it's around for 2 years now. Again, this actually came out of the Affordable Care Act. We had our first version of the quality strategy in 2011. It's now been updated twice. There is a toolkit on the website for, I think it's hosted under ARC. And it really echoes this idea of the triple aim. So better health, better quality of care, and decrease cost. So always trying to balance those three. So as part of that, there's a number of programs that have been implementing in a variety of ways, again, to try to change the way we pay for care. So it's not a transactional payment, although we still do a whole lot of that in California, but looking at the outcome. So under Medicare, reducing hospital readmissions and having the statement, well, we're not going to pay if you readmit within 30 days. It's driving hospitals to look at how they work with their partners in the discharge planning process and the care coordination to make sure that people are able to get care and not be readmitted. The idea around provider preventable conditions is very similar. You shouldn't go to the hospital to get sick and get injured. That's not appropriate. So we want to make sure that's not happening. And part of the way to help incentivize that is to tie that to payment. And then in other areas, looking at core quality measures. So we received a grant to look at that for adult quality measures at healthcare services. Also looking at incentives. So we have a $10 million grant through the Centers of Medicaid and Medicare and Medicaid Innovation around incentives for quitting smoking. So the Medi-Cal population has a higher smoking tobacco use incidence than the rest of the population. And this is a grant to look at incentivizing the use of the tobacco quit line to see if we can help decrease that. And then there's many others, lots of programs. So shifting again a little bit more into this, we as California, our Health and Human Service Agency, we received the California State Innovation Model Grant. CalSIM, that's where I got the California from, is our version, and we've been working very diligently on that, developing a plan with a significant amount of stakeholder input, many folks from this room, in terms of, again, looking at how we're going to pay differently, and it really has built off of the framework that was established through the Let's Get Healthy California Task Force. At our summit in May, Secretary Dooley and Pat Powers shared this with all of you. And it's built on this framework in terms of looking across the whole lifespan, early beginnings, healthy living all the way through, considering end of life, making sure we think of those distinctly different, because they happen at all times of life. And then how do we shape that and change that in terms of the different pathways and looking at the delivery system, the community, and the cost factor. So this, again, was one of the frameworks that was shared at the last summit, so wanted to remind folks of that. And again, key building blocks on the bottom there, the bottom left, health information exchange, the idea around clinical and administrative data being a framework for being able to measure how we transform care. And so we're wrapping up work on that plan, which will be going forward to the federal government, and hopefully we will then be pursuing the implementation part of that grant opportunity. But right now we're very thankful to all that have participated in that. So with that sort of backdrop, lots going on, I want to turn it over next to Tom Williams from the Integrated Healthcare Association to share some of the experience that they've had, and then he will pass it on to Ann to speak from the CalPERS perspective, because there really is a significant effort that's crossing multiple payers, not just Medicaid, Medicare, but across these other areas in terms of how we change the way we pay for care and the role of health information in that.
Thanks, Lynette, and thank you, Pam, for inviting me. I'm really excited to be here today with you to talk about how we've used data to help create change. And really that's what this is all about, is improving the quality and the affordability of healthcare. And so I come from an organization that most of you are probably not familiar with, the Integrated Healthcare Association. And our work is primarily in the private sector. So I just want to give you a little snapshot of who we are. We are a California leadership group. We're incorporated as a nonprofit association. We are not a trade association. We don't lobby. In fact, our bylaws actually require equal representation from physician groups, hospital systems, health plans, and then a wide variety of academic, government. In fact, Ann Boynton is a member of our board, as well as a number of other government officials. And really what we're about is trying to bring these different parties together to improve quality and cost. And the use of data is really central to our work. In fact, there was a little mention of the California Cancer Registry. One of our projects is working with the registry to combine claims data with cancer registry data to be able to really take a hard look at outcomes in cancer. But I want to talk to you about another example, actually. And one of the most important uses of data, in our view, to create change is in terms of transparency. And so that has many different applications from a population perspective as well as from a more localized perspective. And I know you're familiar with this, and what I want to do is give you some examples. Clearly, one of the great things about looking at broad sets of data across large populations is the ability to really understand variation. You know, there's a lot of talk about this, but if you can put it in the hands of the physicians in the hospitals and show them how they compare and where the variation is, that can be very powerful. Also, to parse out price utilization and quality. You know, a lot of our work is about trying to reduce increases in costs. And we have some providers that great quality. We also have some that are very expensive. And often what you'll hear from them is, yeah, we're expensive. However, our utilization's lower. So it doesn't matter what we charge. We're actually not costing you more. Or we have really high quality. So if you don't have all those different data sets, quality, cost, patient satisfaction, and the ability to put them together in a reliable, meaningful way, you can't parse that out. So I'm going to show you an example how we're beginning to do that. So the example I want to use is a program that's been in place since 2003. It's called Pay-Per-Performance, and it involves, well, it was 8 major health plans. We added a couple this year, but 10 commercial health plans around the commercial HMO population, about 10 million members in California. Care provided by about 30,000 doctors and about 200 physician groups, including 28 Kaiser Permanente groups. So back in the early 2000s, when managed care sort of got pushed back and the incentives around utilization were pulled off the table, the plans began to measure quality. But they all did it differently. They had different measure sets. They were looking at different slices of the population. So we were asked to get the plans together and come up with one measurement set, which we did. It started with about 28 measures, quality measures around clinical quality, use of HIT, structure, and patient satisfaction. When we began, use of HIT was use of HIT for population health, point of care. Population health, registries, point of care, an example, e-prescribing. And it really promoted the use of registries amongst these groups. So I was really interested to hear the prior talk. So the plans agreed first to take all the data, let us pull it, aggregate it from both the physician groups and the health plans, and then score the physician groups on quality once. That is, we didn't look at Health Net's population versus Blue Cross's. The physicians got measured with their total population, and they really, it was much more reliable and valid. So that was a big step. As time went on, we added other measures around appropriate resource use and total cost of care, and I'm going to show you some of the data in just a second. Now, the other thing I want to make sure is in terms of use of data, there was incentives against this as well. The plans agreed to use the aggregated data results and pay incentives for those groups that improved in quality or showed high quality. To date, about $450 million have been paid by the health plans to the physicians over the course of the last 10 years. And one point I'll make is along the way, we changed our HRT to comply with meaningful use, and I think maybe we'll talk about that. So now the commercial plans are paying incentives for the same meaningful use criteria that the government's paying. So here's an application of transparency. And the data that we collect, the scores that we put out are on the Office of Patient Advocate website. So consumers and providers can see this and see how they're doing. This is just one screenshot that shows star ratings by medical group in a certain part of the state. Also, many other uses of this data. This is these bars are shows the distribution of physician groups across the states for a single measure, immunizations for adolescents. And this is a fairly new measure for us, so you see a pretty big leap. From 2011, the average was about 70% appropriate use of these immunizations across this large population. And in 2012, that went up to about 80.4. One thing we find is when we introduce a new measure, there's usually a pretty good jump that first year. A lot of it just because the data collection gets better. But there's also improvement year to year. And we've been able to track that across the 89 measures that we have in our program. Another use of that data is this. This is a distribution. Each bar is a different physician group. So we can distribute that across all the physician groups in the state, show them where they rank, set some targets, and then we use those targets to set the targets for the incentives. This is chlamydia screening. Interestingly, this is a measure that the Department of Health and Human Services in California asked us to add to our measure set in about 2004 because there was a real problem in this area. And we've seen, this chart doesn't show it, but there's been quite an improvement. We were also measuring, as time went on, it became clear that it wasn't just about, couldn't just be about quality, it had to be about cost as well. So we introduced some appropriate resource measures, which I'm not going to show you, but probably the most powerful measure that we've got today is total cost of care. So this is risk-adjusted, geographic adjusted total cost of care for a physician group to take care of a population over the course of a year. Each one of these dots is a physician group. And you can't really see it, but these are organized by regions. Inland Empire on the left, headed to my right, Los Angeles, Orange County, San Diego, Central, kind of a mishmash, the Central Coast, Central Valley, and northern rural regions, and then Bay Area, Sacramento. The line down across the middle is the state average, and you can see there's a lot of variation regionally and across the state. And one of the great things about the application of data across a large geography and a large population is it's really informing. When we first started and we looked at this kind of a map for quality, one thing that became apparent was those geographies within the state that are low socioeconomic, the physician groups had low quality ratings. So we were able to parse into that and understand that those physician groups had a lot of uninsured patients, no payment, a lot of Medi-Cal, low payment. They didn't have a lot of market clout, low commercial payment. They didn't have the resources to build a registry, hire a quality medical director, et cetera, et cetera. As a result, a lot of action was targeted at those communities, such as the Inland Empire. So I'm going to wrap up in just a sec here. I talked about the difficulty when you only have one screenshot of this, that you just know price or just know utilization or just quality. This shows quality on the y-axis, a composite score, total cost of care on the horizontal axis, and what this shows, the correlation is 0.166, not very high. What this says is that the correlation between quality and cost isn't that high. Interesting. And now you're able to parse this down and by measure many different ways. But this becomes really helpful. So today, our incentive program is a calculus of quality, patient satisfaction, use of HIT, and cost and appropriate resource use. So it's really a value equation to what Lynette was talking about. This is helping drive value-based payments. So I just want to make one other point, and that is when we started, well, no, let me two other points. Some other uses. So this data not only can drive value-based payments, bundled payments, primary medical home payments, P4P payments, but it can help to tier networks, not just on costs, but on quality and value, and other applications that are important to consumer. And you're going to hear Ann talk about one of these listed up here, which is reference pricing. So I just want to make one other point, and it's about data collection. I think it's really important. We need business cases, use cases that will support health information exchange. And one of the things that these health information exchanges struggle with is how to get paid. They can't live on grants forever. So this sort of work is really critical. And when we started, this was our data collection. It was very avant-garde at the time to aggregate this data, but as we look at it today, it's very clunky. You go to the IT department, you get in line, you say, I need all this data. You pull it in and you create a big old honking database, and then you kind of churn through it. So today, it has to be quicker, cheaper, and more accurate. So we have the great fortune to be piloting something we're really excited about through a grant from Cal Ojai. And this is the future. And really what it is, it's kind of an HIE, but it will sit and link with regional and local HIEs around the state. And basically, our main business use we're after is performance measurement. It's a direct query model. Direct query software is put on the host organization's registry or various claim system, their various data systems. And then we send a query. We want to check the chlamydia rate. Query goes out, scores are made, up to the cloud, pull it in, and we can do it much more frequently and much less expensively. So very excited about that. Thank you to Cal Ojai. And we'll have more to report in a few months. And with that, I'm going to stop. Thanks.
Is it pointed the right way?
Yes.
All right, he says it's pointed the right way. Oh, there's a little flashy clock here. I like that. Okay, good afternoon. Ann Boynton. I'm a Deputy Executive Officer at CalPERS, the California Public Employees Retirement System. For those of you who may not be steeped deeply in our lingo. CalPERS, along with being the retirement system for the state of California and about 2,200 local government entities, is also the second largest purchaser of health care in the United States. The federal government does purchase more health care than we do. I oversee the programs that do all of our health care purchasing, our plan management, and our research around the plans. We spend about $7 billion a year. As you can imagine, with that much money every year, I also have an enormous pressure, as does our board, to find ways to reduce the cost of health care overall, because that's a significant cost. If you've seen the papers, you know that we've got a lot of local governments and even the state who are struggling under the weight of all of the requirements that they've got. And healthcare is one of those areas that continues to rise and continues to add pressure. We are fortunate that we have a very large database, have about 10 years worth of data in that database, which is every encounter for every single individual who is covered by our plan. So I don't know how much big data big is, but ours is kind of big. It does afford us on an annual basis and on an incidental basis the ability to do some evaluations. We know what the trends are of what's costing us the most money. We know what percent of our population is obese. We know what percent is diabetic, and it's a significant portion, by the way. We know how old our average people are. We know what maternity is costing us. We know a lot about how we spend the money that we spend. And so one of the things that we're starting to do is think about how can we use that information and drill down into very specific areas and change the way that we reimburse our providers to change the overall cost trajectories of healthcare. Tom alluded to this, and many of you know this. There is fundamentally no correlation between cost and quality when it comes to healthcare delivery. And this is particularly true in a hospital setting. Many of you know that the more actually that you do a particular procedure, the better you're going to be at it and the higher your quality is, but that has no correlation to how much that should cost. So we decided to take a look. Osteoarthritis is a very high cost driver for us. We cover people from birth to death because we are a retirement system and carry all of our members into retirement. Osteoarthritis, particularly as people get older, and I mentioned earlier some of the other conditions that our members suffer from significantly. So it's a big number. When we did this analysis in 2009, it was about $500 million. Drilling further into that, we started to look at, well, what are knee and hip replacements costing us? So clarification for the clinicians in the room. Single joint, elective, knee or hip replacements. This isn't bilateral. This is not anything emergent or traumatic. These are things we've known about for months in advance and have finally decided that, that the correct course of action is to go through a replacement. So what you have in front of you is data that was actually done retrospectively. We did not have the non-CalPERS Anthem enrollee data available to us at the time we did our analysis. The two numbers that the number that you see at the beginning, 28,000 was the amount of money on average that we were spending for single joint knee and hip replacements at all facilities. And then let me disaggregate the acronyms that are there. RBP, reference-based pricing, and I'll explain what the program is in a moment. Those facilities at that time were about 22,000, but the non-reference-based pricing facilities were about 35,000. We also know that the price, these are the averages, the price ranged at those facilities that our people were seeing between $15,000 and $100,000 for the same services with no differential in cost, in quality, on an outcome basis. So we thought about what could we do around for a program around this. We know that quality is not dependent on cost. We know what we're spending on average, about $28,000. So we looked at our facilities across at the hospitals that are in the Anthem network across the state, looked at what they were charging, looked at the distribution of our membership against those hospitals, because we can do that with data overlays and see who's going to which hospital around the state, and picked a number, not completely randomly, but said, okay, to get adequate distribution across the state for our facilities, if we're going to create a program that says, we picked a line and we're not willing for the hospitals to pay you more than $30,000, we needed to know that we had appropriate access to quality hospitals across the state before we went ahead and made that big decision for our members. So it started out with 46 hospitals across the state. $30,000 was what we told the hospitals we were willing to pay. Just based on what we knew they were charging, that's what those initial 46 are. There's a quality gate, then a price gate. Because cost does not equal quality, but low cost does not necessarily mean we're getting high cost, doesn't mean we're getting good quality. So we had to have a quality gate, and then we went into what the pricing would be. $30,000, and that's facility only. That's not the physician, that's not the surgeon charge. The surgeon charges actually are fairly consistent. It's not that big of a problem. So we implemented it as a pre-auth program. This is in our PPO program, so it's a pre-authorization. We knew they were coming. Anthem did a lot of outreach to these people and said, here are the 46 hospitals that you can go to have your knee or hip replaced, and we know that they will charge you a figure that we will be able to pay. If you want to go somewhere else, you can do that, and we will pay that hospital $30,000. But if that hospital is going to charge you $60,000, that $30,000 delta is on your dime, not ours. Which sounds a little harsh, except that we had the hospitals across the state that we knew provided that provided right pricing and that had quality gates and that could do the surgeries for us. So we really were not that worried that what we would end up with were hospitals that couldn't do the work. I did not bring the list of who those initial 46 were. That's one of the questions we get. So like, yeah, who's doing it for you? It was Stanford, Loma Linda, UCSF, UC Davis. These are high-quality hospitals across the board in all the work that they do. So this graph shows you, this is a retrospective analysis through about through September of 2012. The blue lines are our CalPERS numbers, and the dotted lines are the non-reference-based priced hospitals. So we knew they were higher to start with. And then the solid blue lines, and the solid lines are the reference-based prices. It's an interesting, that radical drop in our data, right there when we implemented the program in 2011, is just cutting off some of those hospitals. And I told you one of them was $100,000. I'm not going to tell you which hospital it is. If you're in the industry, you do know who that hospital is. But if 5 surgeries in that hospital is $500,000 that fast, and they were doing more than that. So we had very good outcomes immediately of people complying. We didn't end up with balanced billing. We had some people who went, early on, January-ish, ended up in a hospital that was not a reference-based pricing hospital. We did not end up with any balanced bill against those. And we saw exactly what we wanted to see, which was an immediate drop in the cost to provide these services to a place that is reasonable. The other, just because you guys I'm not a data geek, but I have data geeks. And they put together this chart, which I think is just cool to look at because it just shows all of the prices settling down in there. We did see, so did anybody trend up a little? A little. There's a little bit of upward flow, but on balance, we save about $3 million a year with this strategy, and it's not, for me, that's not a lot of money on an incidental basis. If I can save $3 million here or $3 million there, eventually it'll add up to like $500 million, and that really helps reduce the overall cost of our care. So I will stop there. I'm happy to answer any questions about that. Do you need that back?
No. Okay. So, since we didn't get mic'd, we're going to have to stand up and do the whole thing over here for answering questions. But we will be able to do that. I think we have about 10 minutes or so for questions. So, unless somebody's ready to jump right up with a question, I will queue one up. Was that a yes? All right. Great.
I just had a total knee replacement, and so I've been looking at some of these figures. For 2011, there were almost 600,000 total knees done in the States. All right, we each have 2 knees, and some of those people had more than one knee. And add the hips on, and we're well over 1 million people had a total major joint replacement out of 330 million people. The costs and the numbers are staggering, really, if you project them all forward. Just wondered what your reaction to all that is, and if we're really doing enough.
I think when we think about this project that we did, and it's received some national attention, Jamie Robinson's done some analysis on it, as has Anthem. We look at this as sort of a shot across the bow to transparency and how important it is that people get to be able to look under the hood of what real pricing is and how that can drive changes in cost behaviors. It's a lot of money. I mean, I have a lot of reactions to that many. One is, a bunch of us maybe should need to exercise a little more and do some other things to keep ourselves in good shape as we age. There's no doubt. I mean, at average $40,000 in a hospital stay for, what'd you say, for $1 million? There's a lot of room to save money if we think about how does the data tell us that that differences that are not material to outcomes are influencing our healthcare costs.
You may want to just,
Yeah, good idea.
maybe we stand in a circle.
We also had the opportunity to work with Jamie Robinson on joint replacements, and one of the things we looked at was the implant cost, the device itself, which is the biggest component of cost. And of course, we saw a huge variation. And these devices are actually, they're all pretty darn good. But we pay about 5 to 6 times as much than they do in Europe for devices that are probably just about as good. And so what that did is began to expose why it's so much more. And I won't go into it. You'll get upset. But that's a huge opportunity for savings.
We're standing.
Oh, we're standing.
We're standing.
Right.
Next question. Yes, sir.
About 10 years ago, you talked about pricing transparency, which I think is a super important thing for the consumer to know what the actual reimbursement costs are, or maybe even the gross charges. Quite a few years ago, there were several large hospital systems and a large integrated health system, at least one, if not several around the state, that developed contracts with health payers where on the explanation of benefit, if you're a PPO, those are the forms you get, where you could no longer see those prices, nor could you see what the procedures were that were actually done. The payers jumped on board, I believe, and I used to be with one. A lot of you that know me know about that. And now all of them have jumped on board and don't give that information out. So the consumer really doesn't have that price transparency at this point in time. Any thoughts on how to push the provider community that's contracting with the payers and the payers themselves? Maybe it'll need to be legislated in the state to try to get that added transparency back. It'll also, by the way, help with fraud or waste. So when we get those EOBs, we know if that procedure was done on us.
Yeah, I'm going to let Tom speak for the state of California because I'm in a PPO for the state. Anybody else here in the PPO? We actually, in the EOB that comes from the state controller has the charged amount, the allowed amount, the amount that the insurer paid, and then the balance that we owe. So we actually, at the state, we do get to see that. Our members do see that in the PPO side. Not at all on the HMO side, though.
So just one other angle on that is many of those same systems also had agreements with their health plans that said the health plan can't share their data with anyone, including us, without their permission. But there was a piece of legislation recently that made that, undid that to a large extent. So that's been very helpful. We can now get that data. And some of the commercial plans are actually doing a pretty good job you go on their website and they know what obviously benefit package you have, and it will show you what you would pay when you go to certain facilities and how that bumps against your benefit package. And there's a great company called Castlight, I don't know if any of you have heard of them, in San Francisco, who is doing a lot of work in this area as well. So improvements are being made.
Thanks. I think one of the systems that created that type of a contract you talked about, I believe it was either CMS or the federal government. One of the agencies went after them and they were told stop it here in California.
Sorry, this may be a little naive, actually, because I'm not an expert in this, but it seems like you have an incredible amount of data, and data is power, and you have the power to actually provide transparency. And you're paying the bill. So it's just, I wonder why you might not leverage that to increase transparency yourselves for the benefit of others, because I noticed the non-RBP folks had a dramatic decrease in their cost, right?
Yes.
So that seems to, like the word got around.
Yeah, well,
Right.
there's no doubt it got everybody's attention. We do have a lot of data, and we do know on a physician and hospital group level where the costs are, who's got high costs, who's got low costs. We actually can't share that information. We have statute that has required the hospitals provide that information to us, but it does not allow us to release that publicly. I do agree that there is a lot of value in appropriate information being scrubbed and evaluated and risk adjusted so that you can share value information that way. We do try to do that in other ways. We can't name hospitals, but in particular.
And the one other piece I would add, though, in terms of data that is available, so Office of Statewide Health Planning and Development does a lot of data collection around utilization, includes cost, and that is publicly available in aggregate form and for hospital-specific pieces. Also, Medicare has been releasing information around cost and charges recently. That made a lot of headlines over the summer, so if you haven't seen that, you might take a look. And then also in terms of utilization of both Medicaid and Medicare, CMS has a number of different kinds of websites that they provide information on that makes that available. ResDAC is one way for researchers to get that kind of data in terms of the de-identified and also identifiable data if they go for researchers to go through the appropriate process. But then there's also one of the ones actually, it's been around for a while, but I just learned about it yesterday morning, so I'm all excited. CMS has put together a chronic conditions data warehouse that combines Medicaid and Medicare data by condition and has cost and ER utilization by state and by HRRA. I think I got that right. And so that would be another place to take a look. So I think one of the other aspects, though, is there's actually more data and information available than people realize that's been aggregated, it's been de-identified, and it's been put together in a consumable way that at least gets folks started. So that would be another resource to take a look at. And I think we are out of time. I see Pam doing the stand. So thank you all.